In this video, I'm going to talk about options of treatment in the first-line setting of HER2-positive gastroesophageal adenocarcinoma. In the recent videos, we've been focusing in this stage 4 or locally advanced unresectable setting, generally palliative, and we showed the mind map of how one thinks about treatment through the different lines of therapy, from first line through second line and transitioning to third line therapy or higher. We've talked about the preferred chemotherapy option with FOLFOX. We've talked and alluded to triplet chemotherapies and where that might be useful. And in the most recent video, we set the stage for biomarker testing and reviewed a lot of the previous videos on molecular testing of tissue and clinical trial design, immunotherapies, and targeted therapies, as well as chemotherapy. So in this video, we're going to be really focusing now on that HER2 positive subgroup and what is the evidence to use anti-HER2 therapy and what is the evidence to use immunotherapy in conjunction with the immunotherapy, all along with the backbone chemotherapy, or in some instances, as I'll show you, with just targeted therapies and immunotherapy in the absence of chemotherapy in select patients. So looking back at the TCGA, or the Cancer Genome Atlas, we learned that gastroesophageal adenocarcinoma can be classified broadly into 4 main biological groups. And so you see the esophagus, which is a completely different cancer biologically. And then we have the esophagus, GE junction, and stomach adenocarcinomas that essentially can be classified as either chromosomal unstable, which is the vast majority, as you see here in purple, the Epstein-Barr virus, which is relatively low incidence, as well as microsatellite instability or deficient mismatch repair, and then genomically stable. It is here in the chromosomal instability, the mechanism that unifies gene amplification, increasing copy numbers of the gene. Remember, we're supposed to only have 2 in each cell, but in cancer cells, particularly in these chromosomal unstable subgroup, they have many copies of gene amplification that leads to extreme overexpression of the protein. And we can see here that HER2, also referred to as ERB2, really clusters as being abnormal in the chromosomal instability. The amplified tumors are indicated here in this graph in red. And you can see all the red that clusters here in the chromosomal instability. In fact, about 10% of gastric and 50% of the esophageal and G junction adenocarcinomas have HER2 gene amplification. Remember, in the targeted therapy and other mechanisms that we went through in the previous videos, we looked at how gene amplification leads to extreme amounts of protein at the receptor, at the membrane of the cell. And so this would be the normal situation where we have a few protein molecules of HER2 receptor at the membrane. But in the setting of having too many genes of HER2, and then you have all of this expression of protein at the receptor, and this leads to constitutive activation. It's always active at the receptor. It's always dimerizing with its partners and leading to a signaling cascade through other molecules into the nucleus of that cancer cell that then reprograms the DNA through transcription factors, turning on the transcription of other genes that lead to proliferation, movement of the cells, motility, invasion of the cancer cells, and of the ability of the cells to survive. And so this is the mechanism of how to HER2 signals through this pathway. So in this slide, it's a review of all of the various molecules that are available as drugs or therapies that target the HER2 pathway. So on the left here, we see that the HER2 gene amplification occurs in about 10 to 15% of gastroesophageal adenocarcinoma, 10% in gastric, a little higher at the G junction and esophagus. Something else to note is that HER2 is mutated, not gene amplified, but mutated. So the gene copy number can be normal, but there is a sequencing change that leads to overactivation of the HER2 receptor, usually on the internal component of the protein in the tyrosine kinase domain. And so this is the HER2 molecule spanning across the membrane of the cell. This is outside the cell. This is inside the cell. And what happens when HER2 is activated, it tends to bind to another molecule in the same family of molecules called HER3, called receptor heterodimerization. This leads to activation internally and then signaling through the molecules, changes in the DNA and aggressive cancerous growth. Again, as a reminder, this is how chemotherapy works downstream to prevent DNA synthesis and cell division at this level. But a more elegant and targeted way to target a pathway that's overactive is to hit the actual receptor that's overactive. And so in this talk, we're going to talk about the evidence of trastuzumab, Herceptin, the first anti-HER2 therapy studied and approved in this cancer type, as well as others. We're going to talk about the internal tyrosine kinase inhibitors, the oral small molecules that you can take that get into the cell and bind internally. Specifically, we're going to look at a study from lapatinib. We're going to talk about pertuzumab, which is an antibody that binds to HER3 and prevents this dimerization of HER2 and HER3, and we'll look at the study that evaluated pertuzumab. And then we are going to look at margetuximab, which is an antibody very similar to trastuzumab, but is engineered to enhance an immune response that we're going to talk about. And then we're going to talk about ZW25, or known as zanidatimab, which is a bivalent antibody that binds to both the epitope or the spot that trastuzumab binds, as well as the epitope that pertuzumab binds, all in one molecule. We talked about these types of things in the introduction and principles to targeted therapies. And so I encourage you to go back and review that. And then finally, we're going to talk about antibody drug conjugate, DS8201A, also known as trastuzumab deruxtecan, or Enhertu, which is an antibody, basically it's trastuzumab that's conjugated to a chemotherapy drug called deruxtecan. We will talk about that in later lines, not in the first line setting in this particular talk. So as a background, we know that chemotherapy can improve outcomes compared to best supportive care. This figure is plotting here the median overall survival with various chemotherapy regimens that are all, the legend of those acronyms are down here. In green are 2-drug regimens, in orange are 3-drug regimens. And generally speaking, we can see that the benchmarks in median overall survival, the 1-year overall survival rate, the 2-year and 5-year overall survival rates are indicated here with just chemotherapy alone. Those are summarized here in this slide. And we referred to this when we were talking about what is the standard chemotherapy for this disease in first-line setting and what are the expectations. But we also know that if we have a positive biomarker and match it to targeted therapy, specifically in this instance where we're talking about a HER2 positive cancer, and match it with anti-HER2 therapy, that each of these benchmarks can be improved for each of these clinical outcomes: response rate, disease control rate, progression-free survival, and overall survival. In the talks about molecular testing and how we obtain tissue, how we process the tissue, how we get a diagnosis, we also alluded to that we routinely obtain biomarker information with immunohistochemistry, looking at the protein expression level, as well as fluorescence in situ hybridization, looking at the gene copy number specifically in this presentation with respect to HER2, as well as obtaining DNA for next generation sequencing of a whole bunch of genes, but including HER2, where we can get the information sort of redundantly and get information on the HER2 copy number from that aspect. In this talk, we're also going to talk a little bit about PD-L1 testing by immunohistochemistry, because that may be pertinent when we're talking about adding an immunotherapy drug to the standard chemotherapy plus anti-HER2 therapy. As a quick reminder, we've reviewed in other presentations how we test for HER2 with immunohistochemistry. Because there is heterogeneity within the sample, it's recommended to get many biopsies from the endoscopic biopsy, optimally 6 to 8. because as you increase the number of biopsies, we increase the sensitivity of catching that HER2. If we only have a few biopsies, we may get an area that was negative and falsely conclude that it's negative. And remember, the pathologist stains it with a HER2 antibody, not the therapeutic antibody, but the diagnostic antibody. And then they can assess based on the brown intensity, how bright the brown is on a semi-quantitative scale of 0 to 3, 3 being the highest intensity, 0 being no staining, as well as reporting what percentage of the cancer cells are staining. Is it 10% of the cells? Is it all of the cancer cells? Is it a subgroup of them? And again, this is important because this is a predictive biomarker for benefit from a specific anti-HER2 therapy. If you're HER2 negative tumor, then it's not expected that anti-HER2 therapy will be effective. And then we also talked about FISH testing, fluorescence in situ hybridization, which is looking at the cancer cell and probing with both a HER2 probe as well as a control probe for the chromosome that it resides on, chromosome 17, so that we can count how many chromosomes 17 there are and how many gene copies of HER2 there are. And in a normal situation, you'd have one copy of HER2 on a chromosome 17 and another copy of HER2 on a second chromosome 17. That would be a normal cell. But in the amplified situation, you see many, many copies of HER2. And so a HER2 positive tumor by FISH criteria would have a ratio of HER2 to CEP17 copies of at least 2 or higher. The higher the ratio, the more amplified it is. You can then subdivide into really high level amplification versus lower level amplification. And we're going to look at that in the next few slides, because this is important as a predictive biomarker. These are the cancer cells with really high level amplification that are the most sensitive to anti-HER2 therapy. And so putting the immunohistochemistry and FISH together in routine practice, this is how the pathologist proceeds, is that they stain the sample, and if there is really strong expression, 3+ expression in at least 10% of the cells, then it's positive and we move on. If, on the other hand, there's no staining or very weak staining, a 1+ score in 10% or more of the cells, then this is considered negative and no further testing. However, if there's equivocal or in between 2+ intensity staining in at least 10% of the cells, then that's considered sort of unsure, and we move to FISH testing as a tiebreaker. And only if that ratio of HER2 gene copies to the control probe is more than 2, then it would be called amplified. If it's negative, then it would be IHC 2+, but FISH negative, and HER2 overall negative, as you see here. So in addition, as I alluded to, when we are recommending to do next generation sequencing and we query hundreds of genes, which includes HER2, we will be able to identify HER2 gene copy number alteration. And again, we talked about many commercially available assays out there, as well as many academic centers that have these next generation sequencing panels that have a long list of genes that they query. But of course, HER2 is on there. And so we will get that information, even if it is redundant, to the other way of testing HER2 with immunohistochemistry and FISH. As a quick reminder, for PD-L1 testing, if you're looking at the slide, you would have these bigger cells are the cancer cells, and the smaller infiltrating cells are lymphocytes or our immune system. And so when we stain the slide for PD-L1, we could look just solely at the tumor cells and basically assess how many of the tumor cells are positive compared to the all of the tumor cells present, and that's the tumor positivity score, versus the combined positivity score, which is not only looking at the staining of the cancer cells, but also any immune infiltrating cells. And so it's an aggregate of all of that over the total number of tumor cells. And it's been shown over and over, as I'll show you in all the slides coming in the next series, that the combined positivity score is more predictive of benefit of immunotherapy than the tumor positivity score. So with that quick background, what is the evidence for anti-HER2 therapy with or without anti-PD-1 therapy in the first-line setting of HER2 positive gastroesophageal adenocarcinoma. So this is the pivotal study that was done 15 years ago, published 13 years ago, and that showed and supported the use of trastuzumab in HER2 positive cancer. And the definition of HER2 positive was a little bit different at that time because it was still being worked out what exactly is positive and which is not. And so to be eligible for the ToGA study, which was the trastuzumab for the treatment of gastric adenocarcinoma, ToGA, was if you had immunohistochemistry 3+ and 10% of cells or higher, or any immunohistochemistry score as long as FISH was positive. And so remember, a ratio of 2 or higher for the HER2 gene copy number. So you could have no protein expression, immunohistochemistry 0 or 1, and be called positive for HER2 if the FISH was positive. This is a little bit different than what we call positive today, partly because of the results of this study, as I'll show you. Regardless, the outcome in all of these patients revealed that patients that got chemotherapy standard, which was cisplatin 5-FU in this study, with trastuzumab, had a longer median overall survival compared to those that got chemotherapy alone. As well as on the right side here, we see the progression-free survival median was higher with the addition of trastuzumab compared to chemotherapy alone. In addition to that, the response rate was higher in patients who had trastuzumab compared to no trastuzumab, about 12% more responses as seen on CAT scans. And then this is an important slide to look at. This, remember, is called a forest plot, which is looking at subgroup analyses. And if the outcome is towards the left of the center line, then it indicates that it favors trastuzumab. If it's to the right, it would favor no trastuzumab. If it's in the middle, then there's no real clear difference. And so you can see in all the patients enrolled, after screening about 4,000 patients, 584 patients were considered HER2 positive and otherwise eligible for the study. You can see that there is a benefit of getting anti-HER2 therapy with trastuzumab, as we showed on the previous slide. However, when you look at the subgroups based on the biomarker, so immunohistochemistry score of 0, 1, 2, 3, all FISH positive, or IHC 3+ and FISH negative. And you can see that this latter group, there's not many patients that fit into that group. So typically, if you're IHC 3+, you're going to also have FISH positivity, which is why the recommendation is if you're 3+, then let's move on. You don't need to do FISH testing. But you can see here on this forest plot that patients that had 0 and 1+, even if FISH positive, really derived no significant benefit from the addition of trastuzumab, and you know, the median survivals were not that much different. In fact, in some cases, it looked like it might have been better in the control arm. Whereas in the 2+ and 3+ FISH positive, you can see that the benefit does lie to the favor trastuzumab, especially in the IHC 3+ group. So in an exploratory analysis based on those results, looking and bunching those patients that had low level expression or no expression of IHC of HER2 compared to those that had 2+ and FISH positive or 3+ with or without FISH positivity, you can see that the real benefit lies in those patients that had higher levels of expression and FISH positivity. And you can see the median survival differences are more profound, more pronounced compared to the all-comer group. And especially in those patients that had the IHC 3+, you can see that the hazard ratio, remember, the lower the number, the stronger the benefit, the more magnitude of benefit. And you can see here that we're talking on the order of almost a half a year improvement in median overall survival in this select group. So as we go through HER2 studies in the rest of this talk, as well as in later talks when we're talking in second or later line setting, this is a principle that is always observed in studies, that the patients that have the highest levels of expression, highest gene copy numbers, are the ones that derive the most significant benefit of anti-HER2 therapies. So with that benefit, what are the added costs in terms of toxicity of trastuzumab? And you can see, like in any study, this is documented very well, where the type of toxicity and the grade on a scale of 1 to 4, 4 being the most severe and 1 being less severe. And you can see the percentages of any given side effect of interest that we're talking about. And if you look at this table very closely, there are no significant differences in the trastuzumab group compared to the chemotherapy group for any of these side effects. There is some rare toxicity of the heart called cardiomyopathy, and that's decreased heart pumping ejection fraction. It's very unlikely to be symptomatic in my experience in the last 15 years. It's very rare to have any symptoms. Occasionally, because we routinely check these every several months with a heart ultrasound to see how the pumping function is going. Occasionally, we see it drop a little bit, but patients don't feel it at all. And we hold the drug for a few cycles and it recovers, and then we can add it back in. But again, that in and of itself is relatively rare. So overall, given the benefits that were observed and the very minimal side effects, this has been a really good success story as the first targeted therapy introduced into this disease. So plotting the ToGA study results on our backdrop figure here of chemotherapy versus best supportive care and then chemotherapy alone median survivals. And now we add the ToGA study results. In dark purple is what the control arm performed in terms of median survival, which is right around what we would expect with chemotherapy alone. And then how the patients that got trastuzumab did, their median overall survival. And this is in all comers. But if we look at those specific subgroups of patients who had higher expression, so basically excluding the IHC 0 and 1 plus patients, and looking then solely at the 3 plus patients, you can see that the outcomes improve in each of those situations. And in fact, what we call HER2 positive now, partly because of this, is IHC 3 plus or IHC 2 plus and FISH positive. And this is the expected result of what we would get as a median overall survival in these patients. So when we look at the benchmark of what we expect in this disease with just chemotherapy alone, for HER2 positive tumors, it's improved. And this slide, you can see here what we now call HER2 positive, where the median survival is substantially longer than the outcomes in those patients who are just getting the control chemotherapy alone. And it's important to note that, yes, this is an important advancement, but there are some patients, extreme responders at the tail of the curve, which we've talked about in previous videos, is that there's almost a plateauing a little bit of the curve, and that there are some really long-standing responders that do very well with this therapy. And so when we look at these benchmark outcomes compared to chemotherapy alone, it is not uncommon for us now to see patients several years out from diagnosis with stage 4 HER2 positive cancer that are doing exceedingly well with therapy. So what other evidence do we have for other anti-HER2 therapies? Well, this slide is going to talk about 2 large phase 3 studies that were done that unfortunately were negative. The first one here is called the LOGIC study, which was looking at standard chemotherapy plus placebo versus chemotherapy plus lapatinib, the tyrosine kinase inhibitor, the oral drug. And you can see here that while the results trended to be better in favor of the lapatinib group, the results were not considered statistically significant, and so this study was considered negative. It trended in looking at some specific subgroups in the Asian population in this study, in patients less than 60 years old, and certainly in patients with the highest gene copy numbers, all tended to do better and improved overall survival. The likely issues with this study are that about 20% of the patients were still IHC 0 and 1 plus, so we wouldn't expect much benefit in this subgroup, and so this would dilute out the effect and make it look or diminish the outcome, and for those that it's really benefiting. In addition, in previous videos, namely the principles of biomarker testing, on heterogeneity, we talked about differences between local testing and central testing. And this was based on local testing to be eligible for this study. But a parallel study was performed from a pathology perspective of these samples in this study, and they were all tested centrally as well, and there was only 83% concordance, most of which were calling patients positive that did not actually have HER2 positive disease based on central review. So there were a lot of patients enrolled into the study that didn't have true HER2 gene amplification. In addition to that, we've talked about how sometimes the primary tumor can be HER2 positive, but metastatic disease is not. And that can occur anywhere between 5 to 15% of samples. And so this also may have a detriment to outcome if you're enrolling patients that the burden of their disease, their bulk of their cancer, and their metastatic sites isn't HER2 driven. It's not going to benefit from lapatinib. And another important thing, just comparing directly lapatinib as a therapy to trastuzumab, Herceptin, that lapatinib doesn't have this antibody-directed cell-mediated cytotoxicity, this immune recruitment of natural killer cells that we're going to re-emphasize again as we go through the next few slides. And so it's well established that trastuzumab is probably a better therapy than lapatinib, and as also contributes to why lapatinib may not be doing as well in this study. In addition to that, generally speaking, adding a tyrosine kinase inhibitor like lapatinib to chemotherapy is a little bit more side effects, more toxic than trastuzumab with chemotherapy. And so more patients would come off therapy with the lapatinib, and so therefore would dilute out an effect of the lapatinib group. And so putting all of these reasons together explains, in my view, why this study was negative with an anti-HER2 therapy for HER2 positive cancers and gastroesophageal adenocarcinoma. In addition, there was a study called the JACOB study that was looking at pertuzumab, an antibody, remember, that binds to HER3 and blocks the binding of HER3 and HER2, the dimerization that then leads to cell signaling internally. And so this drug, as with lapatinib, were both showing benefit in breast cancer HER2 positive disease. And so both of these studies were expected to be positive in gastroesophageal adenocarcinoma. And so this JACOB study was evaluating the addition of pertuzumab to chemotherapy plus trastuzumab versus just chemotherapy plus trastuzumab control. And so you can see when the study read out, though, that the pertuzumab group, while it trended to being better, it looked like the median survivals were higher. It wasn't statistically significant. And some reasons might be that this, although it did exclude patients that were IHC 0 and 1 plus, which is a good thing because we now recognize those patients don't drive much benefit, but it did still have about a third of patients had the lower expression of HER2 compared to the higher expression IHC 3+. And we've seen over and over that the more IHC 3+ patients that are enrolled in such studies will help to push the result in a positive way. In addition to that, while this study is classically considered a relatively large phase 3 study, when we get to the immunotherapy studies, which have 700 patients in each arm, this relatively small. And so we also learn in the principles of clinical trials that if we have more patients enrolled, we can find smaller differences with more success, more sensitivity. And so it may not have enough power to, or enough sensitivity to find the lower difference. And if a study was done that was twice the size, this probably would have been considered statistically significant, and things may be different today. However, this is the only study that we have looking at pertuzumab to date in this disease and in this first line setting. And so it is not a standard option. So lapatinib and pertuzumab, negative studies in the first line setting and not considered standard. So this is in stark contrast to breast cancer, where in breast cancer, studies with trastuzumab, studies with lapatinib, or studies with trastuzumab plus pertuzumab were all positive for breast cancer. Whereas in gastric cancer, we've shown only the ToGA study with trastuzumab was positive, but the LOGIC study with lapatinib and the JACOB study with pertuzumab were negative. Why? Well, simply breast cancer and gastroesophageal cancer is different, but more detailed response would be that the heterogeneity within a patient of the HER2 positivity, I think, plays a larger role here than in breast cancer. And so some cells are HER2 positive, some are not. And so this can explain to some degree why these studies are negative. And in addition to that, I showed that a lot of patients enrolled were actually HER2 negative to begin with. And so we wouldn't expect a benefit in them. And so it dilutes out the effect. Regardless, these studies have led to the first-line therapy standard of only trastuzumab as an option to be added to chemotherapy. So what about immunotherapy? In the principles of immunotherapy, we introduced the concepts of an innate arm of immunity where the natural killer cells reside, and we introduced the acquired immunity where the cytotoxic T cells or CD8 cells reside. And so I encourage you to go back and review that specific video when we talk about immunotherapy so we have an understanding. And in that series of videos, we talked about the cancer immunity cycle, where cancer cells release antigens and to nearby lymph nodes where T cells are primed and activated and trained based on specific binding of major histocompatibility complex and T cell receptors, and select for T cells that can recognize that, and those T cells expand and then travel through the bloodstream to where the tumor is and kill it, ideally. However, we also learned about all the red steps along the way that can inhibit that process. And then we talked about various treatment strategies in green that can try and regain control at each one of those steps. To date, in HER2 positive disease, the most studied way of doing this is with immune checkpoints, with PD-L1, PD-1 axis inhibitors. And so we're going to focus on that, and specifically where they act is in this peripheral domain at the site of the cancer. In addition to that, we're going to talk about how antibodies like trastuzumab and others that are engineered to specifically enhance this effect, like margetuximab, will drag in natural killer cells into the region of the cancer through the back end of the antibody. So that's shown here in this slide, where the antibody itself, trastuzumab, blocks receptor dimerization and activation, and it also leads to internalization of that receptor into the cell and degradation of the receptor, so it can't signal anymore. But in addition to that, as it's binding on the outside, it can activate the innate immunity by eliciting an immune response called ADCC, or antibody-dependent cell-mediated cytotoxicity, where the back end of the antibody binds to NK cells, natural killer cells, and that leads to destruction of the tumor through this immune effect. And these natural killer cells bind to the back end of the antibody. Remember, the antibody looks like a Y, and the top parts of the Y are where the antibody binds to a specific site, in this case, HER2 epitope. And on the back end, called the FC domain, is where the NK cells will bind. And on this complex slide, where we were showing all the different ways that natural killer cells can be enhanced, we really focused on ADCC, the first part here, where the natural killer cell, through its receptor, binds to the back end of the antibody, which is binding to a cancer cell through any antigen. In this case, we're talking about HER2 with trastuzumab. And the next topic to discuss is how therapies can be enhanced to improve this ADCC response. And to understand that, we have to go back and remember that we inherit 2 copies of every gene in every cell. And so the gene that is encoding the receptor on the NK cells, called Fc gamma receptor 3 or CD16A, there are different versions of that receptor in the human population, 2 main versions called the V allele and the F allele. The V allele has very high affinity, meaning it is really sticky to that FC domain on antibodies. And if somebody inherits 2 copies, one from mom and one from dad, which accounts for about 15% of the population, they have very, very strong affinity of NK cells to antibodies. And so they tend to have a better response to antibody therapies like trastuzumab. On the other hand, if you have two copies that are F copy or versions that are low affinity or low stickiness, which is the majority of population has at least one, if not two, then this response is dampened. And so agents like margetuximab are drugs that have been engineered that can enhance this binding here between the Fc gamma receptor 3 and the Fc domain by engineering a different Fc domain on the antibody. So margetuximab is built on trastuzumab. It has the same other end where it's binding HER2, but it's been changed here in sequence so that it will bind strongly to NK cells, irrespective of what the alleles are in patients that are getting the therapy. And so this is to overcome the low affinityness in the majority of patients. So that's margetuximab is sort of like a super trastuzumab. In addition to this, whether or not you have trastuzumab or margetuximab, when you do have a response to the cancer treatment and you have destruction of the cells, we talked about the cancer immunity cycle and how these antigens will filter down into lymph nodes and start to select for T cells that can now enhance and elicit an immune response. However, then we can have upregulation of PD-L1 on tumor cells that shuts down or dampens the T cell response. So this is where immunotherapies like checkpoint inhibitors to PD-1 and PD-L1 become interesting. And so we have in this figure, just as a quick review, cancer cells that can express antigens on their class 1 MHC molecule. And if a T cell enters that has a specific recognition, like a lock and key of this, then the T cell can attack this cancer cell as being abnormal. However, a PD-1 receptor on T cells and PD-L1 receptor on cancer cells can dampen this response. This is a negative interaction. And this is why checkpoint inhibitors, immunotherapy drugs that are antibodies that bind to either PD-1 or to PD-L1, effectively doing the same thing, blocking this binding, then allows this T cell to proceed to kill the cancer cell. And there are a number of examples now and growing of options of anti-PD-1 and PD-L1 therapies. We are going to focus in this HER2 talk on Pembrolizumab, which is the most studied in HER2 positive disease, and in fact, the one that is approved in the United States. We also talked about how PD-L1 is scored with combined positivity scoring, and you can see examples of completely negative or low levels versus strong levels. And when we think about different types of tumors that fit into these different categories, generally speaking, those tumors like Epstein-Barr virus and MSI-high tumors, those two categories of the TCGA that we talked about earlier in this talk and in previous talks, tend to have really high expression levels, whereas diffuse type of genomically stable signet ring usually have low or negative PD-L1 expression. And remember, this therapy is trying to interject into this cancer immune cycle in this region here at the periphery where the T cells are in the tumor bed at the area of the cancer and trying to inhibit this, this actual interaction. So what is the evidence of adding immunotherapy, checkpoint inhibitors to anti-HER2 therapy with or without chemo? On the left, we see here in the first line setting, a phase 2 single arm study that was looking at standard chemo with trastuzumab and the addition of pembrolizumab in all comers other than being HER2 positive. And you can see in this 32 patients, this waterfall plot that showed a nice response rate higher than what one would expect with just anti-HER2 therapy and chemotherapy alone, as well as at 87%, as well as a really good disease control rate. On the other side, in the second line setting, we had a study that was a single arm study, a little bit bigger in terms of numbers of patients, that was looking at after failure of first line therapy, failing chemotherapy plus trastuzumab, patients were eligible to get a chemo-free second-line option of just margetuximab antibody and pembrolizumab antibody, anti-HER2 and anti-PD-1. And you can see the outcomes of survival plotted here by molecular subgroup. And so you can see here the patients who do the best, potentially not surprisingly, are the patients that had highest levels of HER2 and highest levels of PD-L1, as opposed to patients who had lowest levels of HER2 and negative for PD-L1. They didn't really derive much benefit at all. And so these two studies paved the way and led to larger studies. The first in the first line setting was Keynote 811, looking at chemotherapy, trastuzumab with or without pembrolizumab, and the MAHOGANY study, which was moving from second line into first line because these results were so outstanding, and looking at chemotherapy plus margetuximab with or without retifanlimab, margetuximab trying to replace trastuzumab, and retifanlimab, a different anti-PD-1 immunotherapy. In addition to this standard classic randomized study, a separate sub-study called Cohort A was looking at this chemo-free regimen of just margetuximab and retifanlimab, but only in patients who were double biomarker positive, really high expression of HER2 by IHC3+, and at least some expression of PD-L1, just because of what was seen and intuitively and what we've learned over the years with respect to these biomarkers. And so first we'll talk about how Keynote 811 reported just a subset of the patients enrolled, a phase 2 or early look at the phase 3 study, and it showed an improvement in overall response rate of 22%. And this led to an accelerated approval by the FDA contingent on this study, reading out for survival with its primary endpoint as being positive. But because that can take several years, this has been an accelerated approval. Before we get to that on the next slide, we also will show you the data that came out relatively simultaneously of just that Cohort A, which I think is important to understand and be aware of. So first, the Keynote 811 study. Again, it was a randomized phase 3 study that was looking at the standard of care, trastuzumab with chemotherapy, either capecitabine, oxaliplatin, or 5-FU and platinum, cisplatin, with a placebo, or the same, but with pembrolizumab. And the primary endpoint was overall survival, but as I showed you, an early look was looking at response rate. And some of the makeup of the study, you can see that a large proportion of the patients were PD-L1 CPS 1 or higher, so a low level positivity. And a large proportion of the patients were high level IHC3+. And again, remember, say, for example, the Jacob study, which I was showing you with pertuzumab a few slides earlier, was 33% of the patients had IHC2+ FISH positive. And so I think we need to pay attention to those types of things, because this study is sort of stacked in favor of having a positive outcome with anti-HER2 therapy, because it's heavily enrolling the patients that have the higher level of the biomarker. And so the response rate you can see in the control arm on the right and in the trastuzumab plus pembrolizumab arm on the left, you can see that the waterfall plot shows more patients responding and to a deeper degree, which is a good thing. Something of interest that we don't know yet is what are the incidence rates of the higher cutoffs of PD-L1, CPS 5 or CPS 10, and what are their response rates in each of these subgroups. And of course, we don't know the progression-free survival or overall survival yet in any of the subgroups, because this is just the first look, just looking at response rate. Of note, the median duration of response is only a little bit higher in the pembrolizumab compared to the control arm. And so even though patients are having a deeper response, maybe it doesn't seem to be lasting much longer among the responders. But ultimately, for now, this is what has led to approval of pembrolizumab only in the United States, nowhere else in the world to date that I'm aware of. And we are awaiting data to mature. The study's completed accrual, but now we're just following how patients do in each arm. And as time goes by, we'll be able to see, is there or is there not benefit in progression-free survival, overall survival, and what are the differences by the different PD-L1 cutoffs? Does it really work indiscriminately? It doesn't matter what the PD-L1 is, or is it important to know the PD-L1 status? Alluding to that, we did see a quick look at a later abstract that showed, again, this is a forest plot looking at a number of different variables. And if things are to the right of the zero line, in this case, what is being plotted here is the response rate, the difference in response rate between the two groups. If it's to the right, it favors pembrolizumab. If it's to the left, it favors the placebo group. And the response rate difference is around 20% in all the parameters, except for the PD-L1 subgroup that is low. And so maybe PD-L1 does matter. Now, this is a really small subset. It's subject to random variation. We always have to be considering that. However, knowing what we know and knowing how PD-L1 seems to always be a predictive biomarker, it seems to be the case here as well. And again, I'll point out that we really want to see this by PD-L1 different cutoffs and see if it really is limited in terms of the benefit to those that have high PD-L1 expression or not, and what is the optimal PD-L1 cutoff. Is it different in the HER2 positive group compared to HER2 negative group? Again, ultimately, all we know so far is the response rate, and we're waiting to see, does this improvement in response translate to improvement in control of the cancer, progression-free survival, and overall survival, and does PD-L1 expression matter? We talked about the MAHOGANY study when we were looking at margetuximab with the anti-PD-1 therapy retifanlimab, and I mentioned that there is a standard randomized study, first looking in the randomized phase 2 setting, just to see if it is worth proceeding to a larger phase 3 study. First question is margetuximab better than trastuzumab? And second question is adding retifanlimab or other targeted immunotherapy drugs to the margetuximab and chemo better than margetuximab and chemo alone? And so it's sort of a 4-arm randomized phase 2 study that then will be proceeding to a phase 3 potentially if these outcomes hit the mark. But what I really want to emphasize, because that study will take a while to accrue and see results, is this other single arm study that was looking at chemo-free just antibodies for super select patients that had really high expression of HER2 and had positivity of PD-L1. And in that group of patients, 40 patients were to be enrolled, and then to proceed or not to a larger expansion cohort if it met its endpoint. And that the response rate had to be higher than like 53% of patients or something like that. And so that result was reported and now published, and you can see that the response rate was right at the mark that was considered to go and proceed to the next stage. And you can see the disease control rate was 73%. So the reminder, this is in the first line setting of patients who are double positive, HER2 positive, and PD-L1 at least CPS score of 1 or higher. And so remember, in the ToGA study, the response rate was 40% of chemo plus trastuzumab. Here we have a chemo-free regimen with a trastuzumab-like molecule called margetuximab and an anti-PD-1 therapy retifanlimab, showing a response rate that's higher than what was achieved in the ToGA study. And above here is is called a spider plot, or as Italians like me call it, a spaghetti plot, where you can see over time the size shrinkage or growth of cancer masses, and you can see that a lot of patients are having shrinkage, and it's durable. On the right here, we see the median progression-free survival, which is pretty remarkable with no chemotherapy, and really remarkable overall survival with no chemotherapy, with just margetuximab and retifanlimab. And as we're going to talk about in the next video, when we get to anti-PD-1 therapy and HER2 negative tumors, when PD-1 therapy is given without chemo, we usually see a steep decline at the very beginning in a lot of patients in both progression-free survival and overall survival. Whereas here in this chemo-free regimen, but it's selected by HER2 positivity and PD-L1 positivity, double biomarker positive with two targeted therapies, we did not see that drop, which is very reassuring. And so the other point I'd like to say is that the median duration of response, as I alluded to here in the spaghetti plot, is that the patients who have a response have a long duration of response on the order of what was seen in the Keynote 811 study of chemo plus trastuzumab plus pembrolizumab. And then finally, the subgroup analysis of patients who had higher levels of PD-L1, so 10 or higher, compared to those who were 1 to 10, 1 to 9. Remember, patients had to have at least one to be eligible for this. You can see again that the patients who have the longest benefit of response are the patients that have high levels of PD-L1, which is no surprise. Even though this is very small numbers, this is very consistent now with what we always tend to see. And so I don't think this is random variation. I think this is what we should expect. And in fact, some of these patients never having a drop of chemotherapy almost 2-3 years now, because this is some time ago, without any cancer and off of the therapy just on surveillance. So this is pretty remarkable, and I would put it in the category of how MSI high tumors respond to anti-PD-1 therapies that we're going to get to in the next video. So the other important aspect to understand here is, how is this regimen tolerated? So chemotherapy with trastuzumab, or chemotherapy with trastuzumab plus pembrolizumab, compared to margetuximab and retifanlimab without chemotherapy. And so you can see here that any adverse event, and remember, grade 3 and 4 are the highest toxicities, the more severe, the rate of a very severe treatment-related toxicity is about under 19%. In contrast to the ToGA study, which is chemotherapy plus trastuzumab, or the Keynote 811 study, which is chemotherapy plus trastuzumab plus pembrolizumab, and in smaller studies of zanidatimab, the drug that binds to both HER2 and HER3 simultaneously as a bivalent antibody in smaller phase studies, all have relatively high rates of side effect profile compared to the patients that are in this chemo-free approach in the MAHOGANY Cohort A study. And that speaks to that most side effects, when we're talking about anti-HER2 therapy or immunotherapy based regimens, come from the chemotherapy backbone. If in select patients we don't need the chemotherapy, we can have really good outcomes in the absence of these side effects, and that's something to be aware of. So my opinion here is that in patients that have really high expression of HER2 and really high expression of PD-L1, I would consider starting with trastuzumab and pembro, or margetuximab, which isn't approved in this disease type, but it's available as a consequence of being approved in breast cancer. And if one could get it, then one could do that. Or because trastuzumab and pembrolizumab are already approved with chemo, one could consider doing just the treatment with the targeted therapies in the absence of chemotherapy, and only add the chemotherapy in if necessary, if and when there's evidence that it's not effective with just the antibodies alone. Something to consider. But regardless, in the previous video, we talked about and introduced the NCCN Guidelines, the National Comprehensive Cancer Network Guidelines, and how they're derived, who is involved in making them, and how they can be applied. And here we're showing on the left the recommendations or guidelines for esophageal and G-junction adenocarcinoma, and on the right is for gastric cancer adenocarcinoma. In the end, they're essentially the same. They should be the same, but there are some nuanced differences because of different studies that were done in only one or the other, and so there are different approvals based on gastric or esophageal G-junction. When we talk about HER2 therapy, as shown here and highlighted, you can see they're identical recommendations. And for the category 1, we talked about, that has the most evidence, phase 3 randomized studies, and that is the ToGA study regimen of 5-FU or capecitabine, the oral version of 5-FU, cisplatin, and trastuzumab. Of course, we prefer oxaliplatin over cisplatin due to lower toxicity, but because it's not category 1 evidence, it's not indicated as such. And down here, we know that all recommendations that don't have a specific category in the table are by default 2A, the next level below category 1. In addition, now we have the Keynote 811, which it's not category 1 because it's not the phase 3 data yet. We're still waiting for that. But on the first look with response rates, the FDA has done this conditional accelerated approval of the regimen of Keynote 811 and Pembrolizumab. And also 2A is replacing oxaliplatin with cisplatin if that was intended or required or desired for any reason. One could do that even though it was not the regimen of the Keynote 811 study. So these are the options for gastroesophageal adenocarcinoma, the same. And this is, again, NCCN guidelines meet periodically to review new data and amend these as necessary. So in summary, we've talked about the first line setting for HER2 positive cancer. What is HER2 positive? How's that determined? And what is the standard therapy and why, with or without anti-PD-1 therapy? Upcoming studies that are ongoing, large phase 3 studies, include that MAHOGANY Cohort B with margetuximab. But in addition to that is a study called the Horizon study, looking at yet a different PD-1 therapy called tislelizumab, along with zanidatimab, that antibody that binds to both HER2 and HER3. And this is a 3-arm study that is evaluating standard chemotherapy and with platinum and fluoropyrimidine with either trastuzumab, zanidatimab, or zanidatimab and tislelizumab. So this study is looking to see if zanidatimab is better than trastuzumab, and it's looking to see if zanidatimab plus a PD-1 therapy is better than zanidatimab alone. And please note that the control arm does not have pembrolizumab here. And that is because everywhere else in the world, pembrolizumab is not approved as a standard option. And in fact, most of the study sites, if not all of them, are elsewhere, not in the United States. And so, again, this is a reasonable control arm at the moment because most patients, that is what they are getting globally. So in this study, we focused in the first line setting in that category of patients that have HER2 positive cancer. We looked at the standard therapy based on the ToGA regimen. We looked at the addition of immunotherapy in the Keynote 811 study, and we also looked at the possibility of a chemo-free regimen in very select patients that may be able to avoid the toxicities of chemotherapy and still gain all the benefits of this double positivity of their tumor with 2 or dual targeted therapy. Stay tuned for the next video, which is going to be now focusing on HER2 negative PD-L1 positive tumor.